Thank you and welcome. This is our second module in the AO North America Trauma Series. For the second module, we'll be discussing the topic of distal radius fractures, and today is our webinar of the series. I'm Marilyn Heng, and I'll be serving as the moderator for today's webinar. I'm very pleased to introduce our two experts for the webinar session. We have with us this evening Nina Su, who is an associate professor of orthopedic surgery at Emory University. She is the clinical director of the Bioskills and Biomechanics Laboratory, as well as the associate upper extremity fellowship director. Also joining us this evening, also from Emory University, is Eric Wagner. He is the director of upper extremity research, as well as also the associate upper extremity fellowship director. Nina, Eric, thank you very much for joining us.
Thank you for the talk.
Just a little bit of housekeeping. So again, here we have the conflict of interest disclosures. Prior to this webinar, all relevant financial relationships have been mitigated. AO North America is an independent nonprofit surgical specialty society dedicated to the care of patients with musculoskeletal injuries. AO North America does not endorse nor promote the use of any product or service of any commercial entity. And any equipment that is discussed in tonight's webinar is for demonstration and teaching purposes only and meant to enhance the learning experience. So the main reason we're here tonight is because distal radius fractures are one of the most common fractures that are treated by orthopedic surgeons. In our series with tonight's webinar and then our journal club and fireside chat, we're really looking to offer to all participants the opportunity to summarize and discuss some of the current concepts in the surgical treatment of distal radius fractures. At the end of this session, we intend for your learning objectives that you will be able to discuss current up-to-date practice and significant innovations in the surgical management of distal radius fractures in the last 5 years, and that you can review current implants, pitfalls in fixation, and complications from the surgical management of these fractures. This is our agenda for the evening. Again, we're going to try and stick to the time as much as possible. And again, we've allotted the last 10 minutes to hopefully answer all of your questions. And just a final plug before we get started. Again, in this module 2 of the trauma series, in 2 weeks, on Tuesday, April 1st, we will have our journal club on distal radius fractures. And then 2 weeks after that, on April 15th, we'll have our fireside distal radius chat. All right, so to get started, as a little bit of a preface, I've been working here at the University of Miami, and actually for the past 2 years, I've not had to think about distal radius fractures because as an orthopedic trauma division, I don't treat them down here. They all go to my hand division colleagues. I'll be moving to a new job in Massachusetts where I'm now going to have to actually start treating some of these fractures. And so my first question to Eric Wagner is, in the last few years, are there any clinical management updates in the surgical treatment of distal radius fractures that I need to be aware of, since I haven't been thinking about it much in the last couple of years?
Love this. Well, it's my honor to be a part of this. I really appreciate the opportunity and appreciate the chance to answer that question and to kind of engage with everybody on this. So yes, so there has been some cool updates. As a shameless plug, Nina and I wrote a evidence-based update on JBJS and wouldn't direct anybody to that to kind of give you a sense in the last year or two of what some of the data that we presented on. My disclosure is not really relevant to this presentation, but I should disclose that the value in kind of PROM collection mentor and a lot of the stuff I'm going to talk about in this, as far as when you're weighing some of the recent evidence, could arise from my mentorship and one of my close friends, Dr. JP Warner. So as I go through some of the updates that you're going to see with regards to value, or at least with regards to some of the new evidence that's emerged within the last 5 years or so, I hope you kind of take everything into consideration with regards to this idea of value, so outcomes, but also consideration of cost, whether this is actual implant-associated cost, but even probably more importantly, the societal cost that we'll talk about. The hospital has their own definition of value, as do the surgeons. And then obviously probably one of the most important is the patients with regards to not only their outcomes, but what they're trying to get back to. So this sort of equation and this principle, I'm going to bring back to many of the different aspects of distal race fractures and some of the updates that you will see throughout this presentation, and hopefully kind of throughout this entire hour that Nia and I had the opportunity to spend with you. So in general, it's amazing how much data has actually been coming out on distal race fractures, by far the most published topic in hand surgery. And it's something that clearly has not only a lot of educational attention, but also a lot of costs associated with it, as there's a fair amount of financial investment. And so this is why this is such a relevant one, not just for hand surgeons, but for trauma surgeons and upper extremity surgeons alike, because there's a lot of data and there's a lot of stuff to distill, and there's also a lot of patience and investment into this sort of area. So I'm going to start and kind of work my way up to surgery. So in general, PT has been a hot topic in shoulder surgery, particularly whether you need to do PT after things like reverse total shoulders or after proximal humerus fracture fixation or other shoulder cases. And I think, it's interesting. This has also has received some attention especially in recent years in the distal race world. So, do you need therapy? Maybe it improves outcomes. Maybe therapy in general has the same outcomes. And in general, on this really nice study by Kevin Chung that he recently published, the home therapy and formal therapy seem to do the same. While this recent study published just this last year suggested that a combination of home and in-person therapy was actually better than home therapy alone. So it's something that I think we're still trying to understand, potentially who benefits. I think the evidence is still out there on whether we actually need to do therapy or not, and then who actually benefits from this. And this kind of goes back to this idea of a shared decision-making model that some patients probably would benefit, other patients potentially not, and then you obviously have to evaluate the costs associated with it. And so there's some other a little bit more controversial aspects. I think surgical indications is sort of one of the ones that we love to sort of discuss with our own fellows and kind of go through. Chris D and Scott Wolf did this really nice study showing that this coronal shift was a really important indication, something that's not always talked about, but has really been supported by this and many other articles in recent years. And interesting, the original LaFontaine and Jupiter articles showing the 3 millimeter shortening, dorsal tilt, intra-articular displacement, those have sort of stood up the test of time for the most part. And even more recently, in this great study that was published just this past year, where if you have those that are treated either operatively or non-operatively, and they ultimately get or settle with more than 5 degrees of dorsal tilt, really their functional outcomes and their clinical outcomes really start to decline. And so I think it does appear that dorsal tilt is probably the one that's stood the test of time the most, especially in these younger, more active patients. So as you're making these decisions on who to treat, obviously you're taking into account the patients, but also like what their goals are getting back to, what's the activity levels are getting back to, and then things like the dorsal tilt, the angulation, some of the intra-articular step off. The elderly is even more controversial, and this is something that we constantly are discussing and debating and seeing if the evidence actually matches what we see clinically. There's been some great studies looking at associations between non-operative issues like median neuropathy or operative issues like CRPS or tendon issues. There's a fair amount of debate on who and if you ever need to operate on some of these elderly patients. Radiographically, it does appear that operative management does improve the radiographic outcomes, but that doesn't always mean it improves the clinical outcomes, as was sort of demonstrated in that systematic review. Some really recent studies out of the Journal of Hand Surgery have shown that over 80 years old, really it's hard to demonstrate improvements with surgery. And this is something I think that's still we're working on better illustrating if that's the case for everybody or just some. 77-year-olds in this other one seem to indicate these malunions were not necessarily linked to patient outcome measures. So maybe that magic number of when you don't need to treat of what's considered elderly, maybe it's 75 to 80. I think we're still trying to learn this. This was a really nice study that I think was one of the first ones to talk about what is a true cutoff in somebody that's quote unquote elderly. And this is obviously from an age standpoint, not a physiologic standpoint. But in this study, the same study that I said 5 degrees dorsal tilt in younger patients. In an older cohort, over 75 years old, it was over 20 degrees of dorsal tilt was correlated with poor clinical outcomes and decreasing patient satisfaction. So, I think this is something that's interesting because without question, the more physiologically active patients or physiologically younger patients, surgery tends to improve their early functional outcomes, their grip strength overall. And there's, when you look at some quality assessments, that surgery does seem to win out, especially in these people that are either working or they're trying to get back to certain high level activities. So, indications, very controversial. I think you have to take into account the functional status. You have to take into account both actual implant costs as well as societal costs. And I think there's a lot of shared decision making in this actual part of our sort of decision making algorithm. Osteoporosis is much less controversial. Without question, distal radius fractures occur well before hip fractures. And as a marker of osteoporosis, it's also been shown that you can start bisphosphonates and it does not impact fracture healing. So without question, when you have somebody that has potentially a fragility fracture, get them in to be seeing, have them be seeing, and that the initiation of this should not impact. And we've seen this through many efforts. The DEXA are on the rise. That being said, unfortunately, the medication used for treating osteoporosis is actually on a decline, and I'm not sure how you show that, how we can understand or resolve that the DEXA are increasing, but medication used for treating osteoporosis is decreasing, and something I think we're still kind of working through. And so this is something I think osteoporosis has a lot of value. I do think it's something that should continue to receive a lot of attention, and hopefully will over preceding years. All right, so vitamin C, this is something that's interesting. It's something that I was taught as a resident that you give to every single distal radius fracture because it helps. However, now there's 3 randomized control trials showing that there's no benefit to vitamin C. And in general, although it's very, very inexpensive, it has equivalent outcomes. And I don't think you can anymore say it's going to prevent your CRPS. All right, now let's say you actually decide to treat somebody non-operatively. Do you need to put them in a long arm splint like I was taught in residency? The answer is potentially not necessarily. I think casts have been shown that they don't necessarily help with fracture alignment. A lot of elderly ultimately will displace regardless what you put them in. And interesting enough, study after study has shown that short arm casts actually are as good as long arm casts, both with regards to patient satisfaction and a lot of the radiographic outcomes. And so in general, I think a short arm cast actually is a very reasonable treatment nowadays for a lot of these. Now, obviously it has to depend on if you're actually trying to hold a specific reduction and some of the other parameters, but I do think this is a pretty safe way that's based on evidence to treat patients. And types of fixation, this is super controversial, right? There's a lot of different ways you can fix it. There's good evidence to support almost anything that you want to do. And when you look at comparative trials, nothing's really emerged. Even XFix has basically been shown to be equivalent to volar plating. And it's hard to say like what's actually superior. In general, it seems like dorsal plating does have a little bit higher rate of hardware complications and some of the tenosynovitis, but for the most part, it's hard to make real conclusions on what's the best. And I think you really should fix this to fracture type. And then finally, Nia's going to talk about this earlier a lot more in detail, but I just wanted to sort of talk about some of the recent studies that have just come out. Really, when you look at fracture fixation, it all boils down to missing the key fragment. That most of the failures that have been seen, like in this study, showed that they missed the key fragment. Usually it's that volar ulnar corner that you miss. And so it's really important when you're doing surgery, you got to get the right, it's not actually what you use to get the right fragment, it's actually capturing the fragment and making sure it's anatomically reduced. Some of the other parameters like dorsal tilt, it's important to avoid that, not only for clinical outcomes, but there's a recent study that just showed FPL pressure actually increases when you have more dorsal tilt and maybe increases the risk of a FPL rupture down the road. So I do think this is something we do have control over, and we can improve with really meticulous AO principles at reducing some of these fractures. And then this is something that's near and dear to my heart, opioid-free multimodal protocols. We've done multiple randomized control trials on this, including in distal radius fractures, and have shown that not only the risks of opioids when you use them and when you have prolonged use in this distal radius fracture setting, but also how you can mitigate them with a nice multimodal pathway. And we have published on this extensively and happy to send it to anybody that's interested. And so final considerations, I think there's a lot of considerations here, a lot of evidence. Hopefully I boiled some of that down to give you at least what's been out in the last 5 years or so. A lot of this is shared decision-making. A lot of this is patient-specific, but there is some cool stuff that's been emerging and that's helping to guide our care even better. So really, really thank you for this opportunity, and I'll turn it back to Marilyn.
Thank you, Eric, for that great summary of current issues in the management. So a little bit along your lines of again, value, getting the value for our costs comes into a little bit of techniques and or implants. Certainly, I've noticed, and a lot of the institutions I'm at, there is much more of a push to try and kind of contain the implants, what we keep on the shelf, what companies. Again, the general bias as an orthopedic trauma surgeon is, knife, spoon, and fork. Whatever the VAT committee has decided we're going to use, we need to use. But are there any new techniques that we should be using? Anything that we really should be pushing our ORs to get for us?
Yeah, thank you. So without question, I think this is something that's relevant, and just like you, we have a similar sort of committees that help to guide a lot of what we have available and what we don't have available. But bridge plating is something that I think has really been a big evolution in my own practice that I did not learn as much in fellowship, and I did not do as much starting out, but has really made a lot of difficult situations a lot better and a lot more simpler for me. And I'm going to sort of talk to you a little bit about this idea and how sort of I think it's relevant for many surgeons out there, not just for the salvage situation. All right, so distal radius fractures in general, we sort of talked about this. They come in all shapes and sizes, and there's a lot of considerations with them. I sort of just touched base on this idea of shared decision making, and incorporating a lot of different factors and how you decide when to operate and what to do when you operate. As clearly, there's a lot of different factors that show. You really, I think it depends on the surgical technique less so than what you're actually using. And a lot of this has to do with what you're comfortable with. And I think in general, the surgeon is going to have the best judgment of that. But I do hope to at least stimulate some thought into this idea of bridge plating, that maybe those listening can start to consider this, especially in some of the more difficult fracture settings. And this is a little bit different than Doug Handel's initial coming out of Harborview. We have a slightly different approach here at Emory, and have some pretty good data coming out in support of this. So, interesting enough, external fixation actually works for distal radius fractures. There's pretty good studies showing that although the volar plate is taken over, X-fixes are work, and this idea of ligamentattaxis really works. And thus, some of the original studies, out of Harvard, out of other areas that Doug Hanna liked to show this ligamentattaxis idea with a bridge plate or an internal X-fix actually worked quite well, especially in some of these high energy mechanisms. And in general, this is what you could expect getting back. You could get back some volar tilt, you could get back some radial inclination, you could get back some height, and get some pretty acceptable parameters. As I showed you, what's not acceptable previously, this volar tilt is definitely within the acceptable parameters and get people back to pretty functional levels. The arc of motion, as you can see, was pretty good. 100 degrees flexion extension, 150 supination. So you can get some decent, especially these were used in really salvage cases, pretty good overall outcomes. So, there's always the question when you ask about bridge plates, do you go to the second metacarpal or the third metacarpal? There's a fair amount of data for both. I think if you're going to the second metacarpal, there's a couple of advantages, and you'll see most of mine are to the second. I do think it improves your ulnar deviation and thus some of the translation. I think it also allows you so you don't have to have a third incision at the actual wrist to make sure the EPL is protected. But the third metacarpal does potentially help with that lunate facet, and depends on your fracture stability. Maybe this is more important depending on the type of fracture you have. I do think wrist arthroscopy is also relevant. Nina's going to laugh, but I love to do wrist arthroscopy in a lot of things, especially when I'm treating fractures, to make sure I have really good interarticular alignment. And this study is really the reason why. And when you look at long-term follow-ups, there's now 4 or 5 long-term follow-up studies, all showing really high rates of arthritis. And this one's a really good example of when you have an interarticular distal radius fracture, you get a really high rate of arthritis. And I think it's at least in part due to our lack of interarticular alignment. And I think if you can get a good interarticular reduction, and potentially with the use of arthroscopy, you can really improve, especially in these younger patients. I'm going to show you some cases and some technical kind of considerations. and then sort of open this back up to Maryland. So this is a classic example, pretty hard fracture. 57-year-old fell. You can see, we often see the kind of subacute presentations at Emory for whatever reason. But you can see the fracture, and you can see how distal this was. You could capture this with a volar plate, but you can see it's almost like that classic kind of pylon type of fracture, and you're going to have very little actual purchase distally. So I'm going to show sort of my technique on this bridge plate hybrid construct. So when I do a bridge plate, I almost always do a hybrid. I'll show you examples where I don't, but vast majority of the time I'm doing a hybrid, meaning I'm doing a volar fixation and a bridge plate fixation. This is a very classic just volar approach. I don't think anybody on this call, hopefully most people on this call, I don't have to talk them through, and they all probably have their own preferences of how to do this. I do think taking the brachialis down is really important in a lot of these fractures. But this is a classic FCR approach. I'm sort of opening up, releasing that brachioradialis, making sure I'm not endangering the second compartment, and making sure, or the first compartment, making sure I'm well free of the thumb tendons. And then I'm going to obviously take off your PQ. I do like this carpal tunnel release. Jeff Yao and others have shown that potentially this could help with acute carpal tunnel syndrome, and maybe even help with some of the CRPS that we see. So I do this either with a knife or with tenotomies. And then ultimately, I and then expose my actual fracture itself. One of the important sort of keys to this is when you have these really difficult fractures, is making sure you're adequately releasing all the fracture fragments, adequately understanding it. And this is before I go to the bridge plate part of it. So I want to make sure I understand where my fracture fragments are. I want to understand what fixation I have, and if I can get by potentially without the actual bridge plate itself. And so I'm kind of reducing the fracture. I'm kind of getting a sense for, if I want to reduce fracture, what do I need to do? Maybe putting a styloid pin or two in there to kind of help reduce it, help hold it in place, and get the sense, what do I need to do in addition to the bridge plate? Then you can map out the bridge plate. There's many different companies. There's many different techniques available for this. I do like this kind of skinny ones. The long skinny ones, I do think that's helpful to actually pass it. Exposing the second metacarpal is pretty easy. You can take the tendons ulnarly and then expose your bone, and then you're going to pass it ultimately along that second compartment into the forearm. Exposing the forearm is also relatively easy. You're going to find your ACRL, ACRB, and kind of go in between the little interval there and find your radius. And then you pass the bridge plate. The bridge plate is going to be passed just in line with that second compartment. You can see it's a relatively easy pass. That's one of the advantages of going to the second metacarpal. And then ultimately, you'll make sure nothing's trapped underneath it. And then I like to fix it actually to the second metacarpal first, get some x-rays, make sure it's nice and centered. And then I will go and fix it in place to the radial shaft. The nice thing about bridge plates, if you fix it to the distally first, to the second metacarpal, you'll get a sense for, you can then get a sense for how much you need to distract, and make sure you don't over distract. And that's kind of an important aspect of this. When you're placing your proximal screws in that sort of dynamic hole, you can distract a fair amount. And you want to make sure you're distracting enough to get them back to an anatomic length, but you don't necessarily want to distract so much that you are going to have some tendon issues and cause some finger stiffness, which can really happen with these. So you can either just pull it yourself, or if there's some sort of a distraction device you have, you can sort of distract it and then ultimately get it to a kind of a reasonable ultimate height and a reasonable reduction. And then you can fix it in place with the sort of rest of these screws. So then you can see kind of the before and after that we have of the distraction. You can see how it kind of aided in that the reduction of this relatively difficult fracture. And then you're going to place sort of the rest of the proximal screws, and then you can see the ultimate construct. You can see then I placed the volar plate to kind of help reduce it in place, and got a pretty good overall reduction once I did this hybrid fixation. So placing the volar plate, I don't necessarily have to show the details of that. I think everybody knows how to do this. One important difference that we do that's different than Doug Handel and some of these others is we do take the bridge plate off usually around 2 months. So usually around 8 weeks. I see them at the 6 week point. Assuming everything looks okay, I'll take it off by 8 weeks. Sometimes it goes to 3 months, but we take it off much earlier, and we do either manipulate them or even arthroscopically kind of release the capsule to sort of help with some of their motion. And you can see the outcomes we got back to. So we got back to, a pretty good flexion, extension arc, and pretty good overall patient-reported outcome measures in this patient in 6 months. Here's a couple other examples. So this is a collegiate swimmer. You can see really difficult fracture pattern, really distal. It's hard to capture that. And you can see the beauty of the bridge plate, in this case with a sort of fragment-specific place, how we were able to get a pretty good overall anatomic alignment and ultimate anatomic reduction of that relatively difficult fracture. This had some nice arthroscopic aspects. The cool thing about arthroscopy is once you put on the bridge plate, you can Dr. Sue and I have had some malunions that we've been able to tackle with the bridge plate, and the use of arthroscopy is really helpful in this case, where you can kind of reduce it into place and then ultimately get a relatively decent reduction using this pin and using the pins and using that probe. Here's another example of a pretty difficult fracture, very distal, very comminuted, and a sort of hybrid fixation, how you can get back a pretty decent reduction. Another example, we just used a bridge plate alone because there really wasn't much volatily to sort of tackle with this. And you can see the reduction we were able to get with that fracture offload in the joint surface. And then another a pretty difficult distal fracture, using a bridge plate alone, getting it back to a better height and restoring it kind of off that volar subluxation that you can see that was happening as a result of the fracture. And another hybrid fixation in a collegiate athlete, and you can see how the bridge plate was able to reduce it pretty anatomically and pretty well overall. So final considerations, in general, there's a lot of considerations. Hopefully the bridge plate is something that you can sort of incorporate, especially with these more difficult problems, especially in that hybrid fixation model. And once again, we take it off pretty early, and our data suggests that if you take it off early, not only do you have very similar overall rates of outcomes, but it actually potentially improves some of the clinical outcomes we've seen. So in general, some tips: don't over distract. I use at least 3 screws in the plate proximally and distally. Make sure you're avoiding that nerve, and remove the plate within 2 to 3 months, at least in our mind. And this is my indications. It's a really hard fracture. It's a high energy distal. These transcaphoid wrist dislocations, it's really helpful for. And some of these that have really bad comminution or compromised bone quality, I think it's a very helpful technique for. So thanks for your time. Reach out to me if you have questions about this or anything else that we're talking about, and I'll turn this back to Marilyn.
All right. Again, thank you for that great mini talk on the bridge plate, Eric. So the next part is, and again, all of us as surgeons, we all have to come to terms with, we're going to have complications, but none of us want to be complacent about them. So Nina, my question to you is, what are the big pitfalls that we may encounter when we're doing the fixation? How can we avoid complications? How do we avoid that, awful feeling where you get your post-op, 2 weeks, 6 weeks, and it's all just falling apart? What can you tell us that'll help us avoid that heartache?
Honestly, nothing breaks your heart more than that as a surgeon, but if you operate, you're going to get these complications. So let me just pull up my slides. As a disclaimer, I have had many complications, I think not more than normal, I hope. But however, I think one of the concepts for distal radius fractures is that, as Dr. Wagner alluded to earlier in his talk, like, you have to actually be a little bit mindful about the fragments. And that's, I think, very critically important for distal radius fractures. And one of the things is, if you look at this, there's column concepts for distal radius fractures. To give you a sense, there's radial column, ulnar, intermediate column, as well as a pedestal, and it helps you to figure out where your fractures are. This is kind of a breakdown of, this is a very simplistic form of, like, where are really the key structures you should be looking at when you're looking at your distal radius fracture. You want to be careful about volar rim fractures, dorsal ulnar coronal, the radial columns, the dorsal wall, and also free intra-articular steps that you want to be able, that you see, identify. And was mentioned previously, some complications are obviously unavoidable, but the technical considerations that can help mitigate some of the complications that we see. This is an interesting study. Obviously, bones are not just bones independently. There's ligaments attached to it. And this is a study that looked at where the fractures occurred about the ligament attachment. So those are important to consider. So this is just a very comminuted distal radius fracture, obviously. And I've just highlighted all the different fragments, and these are what you have to really think about. To me, I've made this talk, instead of talking about all the evidence about it, I've really thought for highest yield, we're going to go through some case complications to maybe make us aware so that when we're looking at these fractures that we can maybe think about what the potential complication is to try to mitigate it. So I'm going to be primarily talking about volar plate complications because volar plating has really taken off. And I think the vast majority of distal radius fractures can be appropriately treated with volar plating. However, there are exceptions. The rationale, of course, it's a fixed angle construct and it's stable despite having significant metaphyseal comminution and transfers that distal fragment force to the intact proximal shaft. Okay, sorry. The benefits, of course, is that you have direct visualization of the volar cortex when you're putting down this plate. There's a pronator fossa where the plate sits very nicely and there's a very robust soft tissue envelope there. And the locking screw technology is often sufficient to hold that distal fragment while the bone is healing with the metaphyseal comminution. And there's obviously less or no dorsal hardware and theoretical less tendon irritation. Less irritation. So of course the negatives is that you might have inadequate fixation, alluded to earlier in some of the slides about that that distal volar rim fragment. And we're going to see some examples of that, of what happens and why volar plating alone, or you have to take special modifications to the volar plating to make sure you capture those fragments. And obviously you cannot see intra-articularly from the volar approach. And obviously tendon pressure increases and potential rupture or irritation. So here are some of the case examples we're going to talk about that are very commonly known complications for volar plating. So you have the unstable volar rim fragments, the unstable dorsal ulnar corner fragments, the radial column fragments, as well as very distal fractures. So first, we're going to talk about volar rim fragments, which are very common. So here you have a very common distal radius fracture. You look at that, oh, maybe my volar rim, there's enough. But actually what happens is if you see this patient had a plate put on, but what they fail to recognize that there's actually a very, very small undisplaced volar rim fracture highlighted by the little arrow there. And then what happens is that now the carpus is going to go with that volar rim. And so this is what you end up with. So now this is where your heart kind of sinks, as Dr. Heng had mentioned earlier, that now the carpus is sunk, the volar rim fracture has translated. So that obviously is something that got missed, had to be buttressed, or you had to some type of dorsal bridge plate to help prevent that from that migration. This is another one from St. Elsewhere, 34-year-old male. Again, distal radius fracture, volar plate. If you look very critically of obviously that volar ulnar fragment, if you look at the original films, if you go back, that volar ulnar fragment unfortunately wasn't captured appropriately with that those screws. So of course that volar rim fragment has translated and shifted. Of course, that's a component of your DRUJ, and now the DRUJ is also dislocated, as well as the fact that the volar ulnar fragment has subsided. Of course, unfortunately, the patient was seen in clinic, however, was missed in clinic at 3 months, continued to subside. Obviously, now the DRUJ is extremely displaced. From St. Elsewhere also had like a 4-month post-op after a revision. Again, they buttressed it, but however, they kept the original plate in, so that buttress didn't buttress that point, and now the DRUJ is dislocating. So these are some complications. You have to be very mindful. You want very rigid fixation for that volar ulnar piece. So potentially something like an offloading, like bridge plate, could have been used in this situation. So here's the question is, how do you actually identify that fragment? So now we know this is a problem. It can lead to these type of complications. So how do you do it? So x-rays, I think, are very important, obviously, as our first step, but CT scans also help us. So what are we actually looking at in a CT scan? So this is a CT of the sagittal. And what you want to do is really look at that lunate facet, look at that volar rim. How big is it? And is it stable? Is it going to be stable with just a volar plate? If not, you need to think about having other tools in your toolbox to help you secure that fragment. Okay. Next is I look at the CT coronal, and that really gives me a sense of, okay, when I do my volar approach, what am I going to see? These are the fragments I need to see so that when I'm going in there, I can look out for it. Next, of course, is your CT axial. You want to make sure you look at that because you always have to worry about DRUJ instability potentially, or if you're not going to secure the fragments correctly, that you might end up with some DRUJ or incongruity at the sigmoid notch. So those are how I use the CT scan to help guide my treatment preoperatively. Pre-op planning is critical for distal radius fractures. This is another situation, 48-year-old male MVC. So you look here, if you look at that fragment, again, you have a volar rim fracture, and it's very small on the volar ulnar side. So you have to know this is one that will develop a complication if you do not have enough fixation to hold that into place. And so you can do it through a litany of ways. And I think one of the things I've tried to highlight is you can fix the same problem multiple ways as long as you first identify the problem preemptively as well as actually do something to address it. So this is one which is shown on some other images where you did fragment specific fixation, but you can also deal with the same fragment using K-wires and a volar plate. So this is another very similar patient. You look again, it's very, very small volar ulnar fragment. This is where you just reduce and temporarily pin to get everything in place. But again, that volar ulnar fragment is not stable. This is a technique that I was taught during fellowship while at Mayo, where they used K-wires and you put it underneath the volar plate. So obviously now many companies have different plates specific to hold onto the volar ulnar fragment, which I think is very reasonable, and I do use those as well. But you can sometimes just use K-wires to secure that piece. It's really identification that's important. You can also use, this is a 48-year-old male, a ski accident. This is actually a volar rim plate that is also used, and that secures it in place as long as you identify. So those are 3 examples of 3 different ways you can deal with the exact same problem as long as you can actually deal with the problems. Next is the unstable dorsal ulnar corner fragment. You also have to identify this and really be mindful of it. So if you look at this 20-year-old snowboarding injury, from the PA and laterals, actually doesn't look so bad. It doesn't look bad, but then you look on that oblique and you see that dorsal ulnar corner. And so that is potentially a problem. So I've highlighted sort of in the schematic where that fragment may be. And it's very small. However, if you really think the blue line represents where your volar plate would be, that screw trajectory has to be fairly ulnar, can't be in the sigmoid notch, but it has to hold that fragment to hold it in place. And I've just highlighted, this is your DRC, and the fragment is circled right there. So you want to be able to make sure that you actually capture that fragment because that can be unstable, that can slip, and then obviously that's going to affect your DRUJ. Next is the unstable radial column fracture. I don't want to neglect the fact that we're just obsessed about the ulnar side. The radial column, although looks more robust and usually is not as big of a problem at times as compared to that volar ulnar fragment escaping, it's still an issue. So this is post-reduction, obviously extremely comminuted, requires surgery. You can look at this and you can look at actually the coronals. There's a lot of metaphyseal comminution there. That is going to fall if you do not appropriately strut that up. So this is, if you look, this is where the volar locking plate is placed extremely ulnarly, but you notice that there is that step right at that radial styloid piece because of the fact that there's a lot of metaphyseal comminution at that side, and there's obviously radial column instability. So that's something you have to actually make sure you secure somehow. In this particular situation, they opted to put in a radial column plate. Again, you can do it many other ways. Either you just recentralize your plate, you use a different type of plate, you use a bridge plate, but somehow you have to be mindful about controlling that radial column. So this is just a 6-week post-op. This is another example of a 44-year-old male cycling, again, comminuted distal radius fracture, reduces, but obviously has intra-articular steps. This is not well reduced in a young patient. So if you look at this patient, so that this patient, obviously, they took the patient to the OR. They obviously identified there was very distal fragments. So this is an example of a volar plate that was placed a little bit too proximally. And I think this is a very important key. Whatever you do, whatever company you use, you just have to be understanding of every plate is slightly different. All volar plates are not exactly the same. And some of them are able to be scooched up a little bit more distal. Some need to really stay very proximal to the watershed line. So you have to be comfortable with the plate, have some understanding of it. So this one, they had, they tried to K-wire fixate those very distal fragments that unfortunately this patient had, which obviously led to failure over time. So you can really show this x-ray at the 8-week post-op when they eventually came to see me. You can see actually that very prominent volar ulnar fragment has completely escaped. The carpus has gone volar and the DRUJ is unstable at this time. So I have the CT, yeah. So the CT, I think, is always very useful to get for preoperative planning. Gives you a sense, okay, you have that big gap, it's widened because of the fact that the fragments have shifted volarly. If you look at the coronal as well, you can also see that the volar ulnar fragment has escaped the plate and is more proximal. So this is one where actually Dr. Wagner alluded to, oh shucks. Dr. Wagner alluded to. So this is a prime example of a patient that could be very well assisted, young patient, healthy, needs their joint for as long as possible. This patient had a scope assisted revision, open reduction, internal fixation, had a bridge plate to help offload, and as well as had a very large TFCC tear and DRUJ instability, so had a repair done. But this is an example of like what happens when you don't look at these fragments and capture them. Another example is when the fracture is too distal. So this is a brittle diabetic 45-year-old. You look at those little bony spicules and fragments, had a volar plate in. The plate is placed fairly distal to try to capture those fragments. And if you look, that plate is very prominent on the volar side. And of course, about 6 months later, patient presented with sudden clumsiness and inability to flex their thumb. So this is a very classic FPL rupture. This plate can also cause it. This patient also had an FPL rupture, actually at 6 weeks after surgery. But this is something that you have to be very mindful of. And so this is obviously a very classic paper, the Soon classification, looking at where you have the critical line and whether your plate is dorsal to the critical line, at the critical line, or past the critical line and along the volar rim. So of course, the pressures increase as you get more distal and volar to the critical line. So this is, if the plate is very prominent, very distal, this is something that you should probably consider removing this plate. Another classic example, which I also want to tell, this is a patient who had a very classic EPL rupture. So if you look, it's like they're able to extend fully on one, they can't extend on the other. If you look at this plate, obviously the most common reason for this is that the screws are too long. Literature has shown that you can actually just have the screws at 75% of the width. So this patient in fact has a plate that is where the screws are not too long. However, during reduction, and if you looked at their CT, they have some bony spicules there. So this is also a complication that you should be mindful of. So the things like the sunrise views, looking at the lengths of your screws, or at least taking off a certain amount to make it about 75% across the width of the screw, width of the depth of the distal radius, is some consideration to prevent this particular complication from occurring. You need to know that this exists so that you can try to mitigate this risk. Next one is a 55-year-old female. This is where the plate is pushed extremely distal. And now you have a potential complication of intra-articular hardware. So this is something you have to also be very mindful of. You got to make sure that when you're intraoperatively, you're certain that your screws are below. Even in the best of scenarios, particularly if it's a more osteoporotic bone, you can actually have intraoperatively that the screws were like subchondral. However, over time, it just kind of, as the fracture collapses, it can end up becoming intra-articular. So it could be one of two things. It could have been intra-articular during surgery, or eventually became intra-articular afterwards. Sometimes what I like to do is put some bone graft in there to help just prop it up while it's healing. But again, this is also a consideration if patients are complaining of a lot of pain. So this is a potential complication as well. So again, this is where the bone is actually, in this particular patient, actually, the bone was quite osteoporotic, and actually the screws were fine if you went all the way from the operative to their post-operative course, and the subsidence of that volar ulnar fragment, which was inadequately captured by this radius plate, ended up causing the screws to get intra-articular. So this is an avoidable problem. So intra-articular hardware is something that we as surgeons can avoid. So it's something that you have to be mindful of. So really, my takeaway points is first is that you have to understand the plate. So whatever plating system you use, whichever company you find most comfortable, you have to use the company that you're comfortable with. And then you have to also fully understand the fracture. I think for distal radius fracture, for our trainees, we spend a lot of time trying to like get them to understand where the fragments are. What is the purpose of the different instrumentation we're going to use, what kind of plate we're going to use, because there's a lot of options, and you need to have all those options in the room before you're going to go to the OR. Next key is to capture the fragments. Again, if your patient decides to go wakeboarding the day after surgery and breaks below the hardware, that's not really as mitigatable as a risk as something where you failed to capture the fragments, or that volar ulnar corner fragment, you failed to identify it, so that's why it slipped, and that's why you have a greater problem. You have to capture the fragments, and that's one of the key ways to actually decrease your complication risk. Last one I can't stress enough is that you have to check your DRUJ. DRUJ instability, and doing something where either you fix it or pin it or you supinate or pronate. I think also the DRUJ sometimes gets neglected. So that's something also, if you want to avoid future complications that are extremely painful to deal with, that would be certainly one of them. Thank you very much. And please, if there's any questions, you can reach out. Stop share, sorry.
All right, thank you, Nina. And yes, we have had people putting in some questions into the Q&A box. Eric has been answering them, so everyone also please do open and you can review as well. So my last question to our experts, and this is to Eric, is again, for some of us, it might be considered more esoteria, and you've alluded to some of this in your previous talks, but what are some of the things in distal radius fracture that, we may not thinking about or using, but you want to convince us that we should maybe consider?
Awesome. Thank you. Yeah. So I sort of want to conclude this whole session talking to you a little bit about wrist arthroscopy with regards to distal radius fractures, and why this is sort of useful, and why how you can sort of incorporate this. And I should disclose, I'm not talking about doing it to repair ligament pathology, because truthfully, that's not been shown to be beneficial. What we are talking about is using arthroscopy, similar that you can do in the ankle or even the tibial plateau, to help with articular step off. So we know if you have articular step off, you do have a very high rate of arthritis, as I sort of hinted at earlier. And in this case, in my mind, the use of arthroscopy is to help to prevent that articular step off that potentially will cause arthritis down the road. About that. So, and once again, not necessarily to fix interarticular ligament injuries. That's not what we're talking about. That's not what I'm here to sort of propose, as this is not something that's been shown to actually be beneficial in the actual fracture setting. So once again, interarticular fracture reduction, particularly in these cases, particularly in these young or more active individuals. And this is where I think arthroscopy is really beneficial. I want to show you sort of a technique video of how to actually do this. So once again, standard volar approach, taking down the BR, you're getting the fracture reduced. So you start just like you do with any other volar approach. You're getting the fracture reduced, and you're doing everything else. So I'm putting the fracture, I'm cleaning it out, I'm getting it reduced, I'm making sure if there's some dorsal inclination, I'm correcting that. I'm putting maybe one radius silate in, or radius silate plus something into the volar ulnar corner. I'm putting my plate on to make sure I'm happy with my plate positioning, and I'm putting something in so that way I can sort of preliminary reduce it. So up to this point, it's just like an open distal radius with a volar plate, no difference at all. The only key is now I put in that original screw. I haven't put in any distal screws yet. And now I'm going to turn to wrist arthroscopy. And one important point with this wrist arthroscopy, we're doing dry arthroscopy. You can see I have that IV tubing connected to a 20 cc syringe. But for the most part, there's not going to be water that's going through this joint. I then am going to use a 6R portal and a 3-4 portal. 3 portal is my main viewing portal to start out with. 6R is my working portal to kind of clean out the joint. This sort of IV tubing can help sort of flush some of the hematoma out, especially if it's a acute fracture, and allow me to sort get a much better visualization of the actual joint itself, and allowed me to start seeing some of the actual fracture characteristics. So then once I can see the fracture characteristics, I'm going to start then sort of playing around with this and probing depending on what I need to do. You can use a probe. You can change your viewing to the 6R if you need to. The 6R will give you a little bit more of a landscape view and allow you to see a lot more of what you're actually trying to reduce and the different fracture characteristics. You can then use this probe to help kind of reduce the fracture. You can use K-wires to help kind of keep complete in place. And the K-wires can be coming dorsally, they can be coming volarly, they can be coming from the radial styloid. But this is all to get that perfect fracture interarticular reduction before you finish putting on the rest of the volar plate. So you can see here, I've sort of put in some K-wires. I'm pretty happy with my reduction. So then I'm going to go in and put the rest of the actual screws into the volar plate. Relatively simply, and then filling up the distal aspect, and especially initially, making sure I like my actual radiographic images, and then filling up the proximal with a combination of locking and non-locking. And then often I like to go back and sort of check my reduction arthroscopically and make sure I'm sort of happy with it. So relatively simple, does not add that much time, and you can get some pretty nice reductions with it. Cool thing is you can also use it for malunions. This is an example of a pretty challenging malunion. So this is a 58-year-old, had a biking accident, was treated at a local hospital. And I'll show you in a little bit. You can see this step off of this, the lunate facet. And initially you're like, oh, not a big deal, probably not an issue, but the patients continued to have pain. And when you look at this dynamic image, you can see why the patient's having pain. You can see how his lunate is basically stuck in the lunate fossa. And he really has no motion through that actual that lunate itself. So you can see how he has this pretty bad malunion that's lost height, but it's also really caused some issues on the actual lunate translation itself. And so when we got a good response to an ultrasound-guided lidocaine injection, we ultimately decided to treat this arthroscopically, so pretty standard approach. And then going to the same thing I showed you earlier, so debriding and kind of cleaning out the joint. I'm going to skip ahead so where we get to the 6R viewing portal and can really get a nice view. So there you can see some of the damage on the lunate. Here you can see your malunion, and it's a decent size. This is a 3/0 shaver, so you can see it's probably a 3 millimeter step off, and you can see why the patient would get arthritis if you left it with this and did not have any sort of issues. You can see why the patient would have some issues. So we decided to do an interarticular osteotomy. So this is using a 3-pore portal. I'm bringing the osteotome through the 3-pore portal to sort of break apart the volar cortex. And I start with the volar cortex initially. I then am going to come back through the dorsal cortex once I've gotten all the way through the volar cortex and kind of like basically create an acute fracture. So you can see here now we're translating, going back to the sort of dorsal cortex. Then we flip to the volar side of things, and now you can see I use a Mare approach, getting on the ulnar side of the carpal tunnel contents and allowing me to sort of lift off this fracture and elevate that volar ulnar corner. So you can see I'm packing some bone chips. I'm going to elevate that volar ulnar corner, create some sort of structural stability to recreate a much more sort of anatomic reduction of this, and then ultimately kind of pin it in place with some K-wires. And then I'm placing this little hook plate on it, and I'll sort of fast forward. So you can see the pretty good overall reduction we got interarticularly. You can see we were happy with that. We finished placing the rest of the fracture. You can see the ultimate reduction we got, getting it back to a pretty level overall joint. And this kind of shows viewing intraoperatively. You can see the damage to the lunate. You can see the osteotomy that we created, and then you can see our ultimate reduction. So the pre-op versus the post-op reduction viewing from that 6R portal. So kind of pretty cool techniques you can do arthroscopically to get pretty good joints. Hopefully between this and the bridge plate and some of the other things that Nina gave you as tips, this helps you to manage some of these more challenging problems you see with distal radius fractures, and shows you some of the cool innovative stuff that's happening both here in the United States and kind of throughout the world. So reach out to Nina and I if you have any questions, and look forward to engaging you with a little bit more of the time we have left.
All right, excellent. Thank you. So again, we have had several questions into the Q&A, which you guys have been fantastic experts in that you have answered all of them and typed them in. If anybody has in our last remaining minutes some questions, again, feel free to type it in. But just maybe to give a little bit of some recap, we've had a few questions about the bridge plate. And my question to you, Eric, is do you have indications for when you're going to use it as a hybrid boulder plate and bridge plate versus when you might do just the bridge plate? And then we had a question about the interchangeability of the bridge plate with an X-Fix. Is there times when you might consider one versus the other?
Yeah, great question. So the hybrid, when I use it as hybrid is when I feel like a bridge plate alone is not going to adequately reduce it, because I'm trying to go for anatomic reduction here, or as close to anatomic as I can, especially in these hard fractures. And so if I put the bridge plate on just distraction alone, you still sometimes will have the volar part kind of brought out volarly, or sometimes you'll have the interarticular part not accurately reduced. That's when the value of using a small or just a regular volar locking plate can really help with your actual anatomic reduction and allows you to even more comfort taking it out at like 8 weeks. I still will take my bridge plates out there if I do them alone at 10 weeks. I do think I use bridge plates alone. I use hybrid fixation way more often than I use the bridge plate alone. But the bridge plate alone, I'll do when I can't really get much fixation, or when I do distract it out and it gets pretty good anatomic reduction. I don't feel like I need to add anything volarly. X-Fix, it's really safe for those salvage situations where you have really poor soft tissue or a really contaminated wound. But for the most part, I feel like bridge plate to kind of replace the X-Fix, at least in my practice. I think those were did I hit them all?
Yeah.
Yeah.
Okay.
Yeah.
I think the one thing is like, I obviously, when I went through my training and things like that, I used a lot of bridge plates. I used a lot of external fixators. So I think the one thing with the external fixator, sometimes they can't control that sagittal malalignment. Some of the newer X-Fixes, you can in fact do that. The bridge plate is much nicer because obviously if you need to supinate and pronate the hand to like work on both sides, you don't have these pins coming out, which makes it hard. So I would say I have migrated away from the X-Fixes and done the bridge plates for ease of doing your surgeries and getting that anatomical reduction.
Excellent. Nita, the next question, again, we had some questions about when you use locking screws, when you're using the volar locking plate, are all of those screw holes musts or just, opportunities? And to add on to that, my question would be, when do you decide to go fragment specific plating over volar plating?
So I think that's, for me, like some of the companies have essentially 2 rows of like distal locking screws that you can use. I don't typically use them all. I use them so that I can support my joint surface and like the metaphyseal comminution essentially. So I most typically will use all those the most distal row. And obviously I always have one up the styloid to hold it. But if for some reason, let's say there's a volar ulnar piece I really want to capture, then I'll use all the screws in that area to make sure I capture it. So it's really dependent. I don't have a hard and fast rule. I usually go based on the fracture and capture it using all the screw holes that are needed to capture the fragments appropriately.
Great. And then Eric, we had one question about your post-op splinting protocol. To tack onto that, since you did allude to it, your post-op pain protocol, what's your mainstay? Is it blocks? Is it NSAIDs? Can you take us through?
Yeah, so the study I allude to and what we've sort of expanded upon, not just in Distal Reyes, but just globally across all of our post-op. So we do a multimodal regimen. We do a block as usual. Ideally, if I can do a long-acting block, I'd love to. Emory's had some cost restrictions that we've been limited on some of the long-acting blocks, but nonetheless, then at least in my mind, there's a really helpful way of doing a multimodal, meaning you're attacking many different pain pathways. And one of these pain pathways is using a steroid dose back. One of them scheduled naproxen or scheduled NSAID, and one of them scheduled Tylenol. The dose back's what we did the randomized control trial on in distal radius fractures. We've also done it in total shoulders and a variety of other instances showing really marked improvement from that dose back. The scheduled Tylenol and scheduled NSAIDs versus not scheduled has been shown. We've also shown in some studies that it's more effective when you schedule it versus giving a PRN. And then we do add on a narcotic if they need it. We found somewhere between 60 and 80% people, or 60% of people don't take a narcotic, and about 80% of people only take 5 or less. And so in general, we just give 5, whether it's Ultram or oxycodone, whatever the provider wants to give. So we've been able to control people's pain pretty reliably. We've been able to not have to give a lot of refills and get the opioids down. As we've shown some pretty convincing data that opioids do increase, prolonged opioid use does increase complication risk, infection risk, variety of other things. So I think opioids are really, really not a great thing, not just for combating the opioid epidemic.
Okay, and final question, because it's a good question. Do you allow your patients to be weight bearings tolerated after your dorsal bridge plate fixation?
So with the bridge plate on or after we've taken it off?
I think it's when you first put it on. So let's say you get an elderly patient who's walker dependent, you fix their distal radius. Are you letting them use that walker?
Yeah, so I am. I'm letting him use the walker. I'm telling him caution on lifting anything over about 5 to 10 pounds in the actual hand itself, but I don't mind loading it like with a walker. But I don't want them to do, especially an elderly patient, osteoporotic patient, is to load it load in the picking up at the more distal aspects of the hand. But I do think the locking fixation we have on the bridge plates in the screws helps to offset some of those issues. So we haven't seen a lot of issues with people loading it. But not weight bearing is tolerated, but I do let them walk. Yes.
Okay,
I'll say, like, I'm a very cautious person for that, for the osteopath. So I do counsel them about maybe transitioning to a platform walker for a certain duration of time. But I would say like 99% of my patients don't actually do that, and they have loaded it doing their walker. And I have, as Dr. Wagner mentioned, I have not noticed a problem as well, even though I do tell them about the option. Some of them don't know that a platform walker exists, sort of. So I do warn, I do tell them if they're able to do it. But yeah, I don't like exactly like what Dr. Wagner, I don't want them picking up stuff or cooking, gardening, like those, like I don't want them to be lifting heavy things. However, like loading directly, because you're also loading through the other side. It's not completely 100% through the one arm. It's usually because it's a distribution. I've not noticed an issue.
all right. Well, again, thank you everyone for joining us this evening. Thank you to our experts who gave us a myriad of good tips. And just a plug for our next session in the series in 2 weeks on Tuesday, April 1st. Please join us for our journal club on distal radius fractures, where we will be discussing these 3 articles on the screen. Again, everyone have a great night.